What is up, everybody? This is my third attempt at filming The Science of Feeling Better. I'm Dr. Joe Camerato with Across the Continuum, and I'm really hoping it works this time. I feel it. I think I've got it all figured out. So this is a presentation that I made a couple years ago that I think is very applicable really throughout medicine, no matter what time it's at. And so we're going to give it a go and see if we can't get this thing rolling. All right, so the overview, we're going to be going over models of pain. The previous and the current ones, seek and destroy mentality, we're learning to be technicians, patient-reported outcomes and how they might skew our idea of what success means. Where does science come into play, how the cards are stacked in your favor, and how we can be deceived, and then the implications of all of this. So let's go over the old model of pain first, the biomedical model of pain. And it's old in the sense of musculoskeletal rehab, at least, and so I'll try and keep everything in that light. Now, throughout the presentation, I do have some direct quotes that I want to read, and this is one of them. All illness has a single underlying cause. Disease is always the single cause, and removal or attenuation of the disease will result in a return to health. And so that's the pretty classic definition of the biomedical model of pain. Classical science readily fostered the notion of the body as a machine, of disease as a consequence of breakdown of the machine, and of the doctor's task as repairer of the machine. And it's been around since about 1662 when Rene Descartes first coined it, but it's been around for hundreds more years than that, if not thousands. The question of is it still useful? I would say yes, if not to help us understand where we came from, then to talk about things that are outside of the musculoskeletal realm and outside of that subjective experience of pain. There are definitely things that still subscribe to this. There's some level that's not right, or something that is needs to be altered directly, things that we can change easily. But again, I want to stick to the musculoskeletal and the pain category here. And so if we were to look at a big kind of chart, the biomedical model would be the small portion within the bigger model, which we're about to get to next. But this picture is from a really long time ago, and I believe it's Rene Descartes' picture of how they used to believe that pain worked. And so we know now that pain is not so much an input but an output, and something that somebody perceives instead of senses, depending on who you ask. And so you can see the picture here, probably from the 1600s, is there's a tube that runs from the foot where the fire is burning this person all the way up to their brain to kind of deliver the pain, so to speak. And so in this sense, the pain would be traveling up. And we know now that there's differences between pain and nociception. And we don't really need to get into that, but I just thought that this was an interesting picture to kind of describe where we've come from and what the thought used to be. And along with that thought, along with the biomedical model of pain, is a seek and destroy mentality. And that is that if there's a single driver for each and every patient presentation or symptom, that we just need to be the best technicians that we can be to look and find those abnormalities or those drivers. You know, everybody in school comes out wanting to be the best anatomist, the best manual therapist. They want to know how to be that person with the x-ray vision, so to speak, so that they can go in and find that muscle that's too tight or too loose, or that, shoulder blade that's not rotating right, or that vertebrae that's sitting on something that it's not supposed to. And there's a few problems with this. The first problem is that abnormal is kind of subjective, honestly. There's such a wide variation and range of people and ways that they can exist, and different ways that their bodies can be, that it's hard to just subscribe to one single idea of what an abnormality is or isn't. And it varies from clinician to clinician. Things that I think are abnormal are probably very different than things other clinicians would say as abnormal. And so definitely something to consider, and that also jumps from specialty to specialty. So the BPS model of pain, or the biopsychosocial model of pain, is the more up-to-date one. And I say more up-to-date because models are things that are really just here for the time being until we figure out a new and better model. But this is what we're mainly working with now. And it was introduced in 1977 by Dr. George Engel. And he said the dominant model of disease today is biomedical, and it leaves no room within its framework for the social, psychological and behavioral dimensions of illness. And he was basically saying we need to stop thinking of these people as machines, and we start thinking of their entire person rather than just their elbow or just their knee. We need to think of them within this psychological and behavioral aspect of society. In contrast to the biomedical model, it recognizes that psychological and social factors influence a patient's perceptions and actions, and therefore the experience of what it feels like to be ill. And so, again, it's just trying to connect the person, their environment, their culture, their social interactions, their psychological and behavioral pieces to what it is that they're experiencing currently while they're sick. And I have a funny comic over here. It's just in your head, right? Because we try and explain that to patients that things are a little bit more complicated than just their structure, and they always say it's just in my head. And so or are you saying that it's just in my head? And it's just in your head, right? So just be positive. The guy pulls his head off and he says, I'm feeling so much better, thank you. So subjective outcomes is one thing that I think helps to skew our understanding of success in the clinic. Patient-reported outcomes are widely used and tracked in clinics to consider whether an intervention was successful or not. But the problem is that outcome measures measure outcomes, and they do not measure the effects of the intervention. And the outcomes of the interventions and the effects of the interventions are very different things, right? If we're taking the success of an intervention and saying that the intervention was the thing, or the mechanism of that intervention was the thing that made the person better, rather than some of the things that we're going to get into, we can get a little bit dicey. And we need to use caution when we're relying heavily on or only on subjective improvements from the patient. Yes, we want the patient to say they feel better, we want them to experience feeling better, but we can get a little bit fuzzy in the middle when we try and think about all of the things that can make that patient better, and we're going to get into a good bit of those at this point. So everybody really just wants to feel better, and that should be our main goal, but we want to do it in a way that is scientific and not just bullshitting the patient, so to speak. So frequently when questioning the validity of a single intervention or school of thought, different versions of one statement usually rear its ugly head, and those are, well, I've seen it work. My patients say this makes them feel great, and as long as I or they get better, what does it matter? And so, we only have to think for a few seconds more past the initial presentation of these to see the issues here. And I think the biggest issue, or the biggest two issues, are number one, because of narratives. We need to understand that the patients take away not only from the things that we do, but the things that we say. And words can harm, and words really do make a lot of influence when it comes to patient care. And so if the narrative of what we're doing is such that it's going to convey to the patient that they're fragile, or that they're not robust, or that there's something that I can only fix, or something that needs to be fixed that you can't manage on your own, then that can be very concerning if it's not true. And then a non-zero risk of harm as well. Whenever we're doing any sort of intervention, there's always going to be some sort of risk involved, whether that be dry needling or taping or manipulations or imaging is a good one. And so understanding that just because things get patients better or make them feel better doesn't mean that there's no risk involved, and we need to take those into consideration, especially if the things that we're doing aren't the mechanism that we understand to be improving the patient isn't the thing that's actually doing it, but there's still harms associated with it. And so where does science come into play? Let's go over the scientific method really quickly here. We make a hypothesis, we test that hypothesis, and we analyze results, and then we communicate those results. And the reason that we use something like the scientific method or controlled observations is because uncontrolled observations, or our anecdote or our clinical observations, while they are a part of science and they are evidence, they are heavily influenced by bias, past experiences, assumptions, and logical fallacy, many of which we're going to get into today. And so science comes in and tries to mute all of those things. It tries to eliminate the human error and stay as objective as we really can. It's not perfect, and there are holes in the scientific method, and the research methods that we use, but it's significantly better than us just eyeballing things and intuiting and trying to logic our way through complex systems. Our ability to utilize study methods like a randomized controlled trial when appropriate aids in decreasing the chance for bias and flaws in reasoning. And just to quickly touch on what a randomized controlled trial it is, we take two different groups and we give one a placebo or use them as a control, and we give the other intervention that we're hoping to study, and we follow them over time to see if there's any differences in their changes, so the changes that we're measuring. And if there are differences, then we try and figure out where do those differences come from, and if there aren't differences, then we try and figure out why that happened as well. So you can rest assured that nature is on our side, right? We have a very good healing system, very advanced. We're all very well aware of the acute, the subacute, and the chronic stages of healing. Now, whether there's hard or fuzzy limits on when those occur or when they stop, I'm not quite sure. But things have a tendency to just get better if we let them. Symptoms, tissue healing, all these things happen, and they all happen to improve with time. Now, there can be instances where they don't do what we hope that they would do, but for the most part, musculoskeletal at least, things generally tend to follow what's called a natural history. We know that low back pain in 6 to 12 weeks will just get better on its own if it's in an acute stage. And stuff like knee pain, subacromial pain syndrome, PFPS, all these things just tend to improve over time. That's as long as we don't scare the shit out of our patients by saying that their kneecap is tracking in the wrong direction or something like that. And so all of these things culminate in us just kind of getting better and our patients just kind of getting better if we let them. Now, there's another interesting topic that I like to talk about, which is regression to the mean, and I feel like this is getting more traction over the last couple of years than it had previously. But basically, it's a statistical phrase that states that extremes regress back toward a baseline the more as we measure them more. And so if we can think of pain as an extreme away from somebody's baseline, then the more times that we check in with that patient, the more likely it is for it to be regressing back towards that baseline, especially if they're really far away from their baseline. Here's another nice quote. The likelihood of a change of particular magnitude is determined by the proximity of the initial measurement to its characteristic level. The closer the level of pain is to an extreme of an individual's across-time distribution of pain, the greater the likelihood of the next measurement being less extreme. And so the farther away that person is, the more pain that they're in, and the more uncharacteristic that is for them, the more likely it is the next time we check in with them for that to be closer to that baseline presentation. And I think that this is a very important and a helpful topic to understand, because it can really alleviate a lot of the need for us to make changes right now and put all of it on us, really. And another, verbatim good quote here from one of the papers from my bibliography. The phenomenon of regression of the mean among patients self-selecting treatment during a pain flare-up may be important in shaping clinicians' beliefs regarding treatment efficacy. The clinician who routinely observes improvement in patients following initiation of pain treatment may attribute the improvement to the treatment rather than to the natural history of the condition. Such faulty reasoning may lead clinicians to regard expensive or risky treatments of limited efficacy as being valuable in the management of the patients they see, and the antidote for such faulty reasoning is insistence on evaluation of treatments by controlled trials. And so the way that I like to think about this particular quote, or regression of the mean, or natural history as a whole, is that patients are going to come in when they are very far away from their baseline, and they're going to come see us when they need the most help. And then with the natural history and regression of the mean, they will just over time get better on their own. The problem is when we are applying an intervention over time, they are going to also be getting better while we're applying that intervention. And the issue here is that they probably would have gotten better even if we didn't apply the intervention, but we are. And so at the end of therapy or rehab or what have you, when they are better, we have the ability to misattribute their getting better to our intervention that we applied during that time of them just regressing to the mean. So let's get into some of the biases and the logical fallacies and things that can kind of cause the skews in our understanding. The placebo effect, I'm certain that everybody's heard of that. It's created by the positive psychosocial context that is capable of influencing the patient's brain, right? We give a patient an inert substance, a sugar pill maybe, and we tell them that it's going to do X, Y, Z to them, and then they experience those symptoms due to that influence that they are feeling. And then we have the nocebo effect, which is kind of the opposite side of that coin, where we get that same context and that same influence, but it goes in a negative direction based on an inert substance. So we can see here how this can affect therapy. We have in the middle of this solid line, which is the specific effect of a therapy. And then if we negatively influence the context, like saying your hips are out or your spine is weak or something like that, you can see how the effects of the therapy are much less than they would be if we were to go in the other direction and tell the patient something positive and say you're a robust organism, or you've been training for a long time, so you're really strong, or this isn't going to be a huge deal. I know that you'll get better. All of these positive things can help to influence in a positive direction. So who's at risk for deception and falling prey to these biases and fallacies? And the answer is everybody, really. Clinicians and patients alike are at risk of misjudging and incorrectly attributing improvement in patient presentation. So one that is interesting is a therapeutic illusion, or basically the misattributing benefit and harm, right? Clinicians and patients underestimate the harms of an intervention and overestimate the benefits of an intervention. Again, imaging is a really great topic here to talk about because for the most part, patients understand images to just be looking to see what's causing the issue, right? I can't tell you how many patients are like, I don't know why we haven't taken an MRI yet. It's going to show us what's wrong. Why aren't you guys ordering me an MRI? And so the patient is underestimating the harms of the intervention and overestimating the benefits. So they think that it's going to show the underlying issue, and so we can just fix it. But they're unaware of all of the harms that can come from that: decreased quality of life, increased risk of surgery, increased medical spending, and increased disability. And so that contributes to the therapeutic illusion, and that same topic can be talked about from the clinician's perspective as well. When physicians believe that their actions or tools are more effective than they actually are, the results can be unnecessary and costly care. Contextual effects is another interesting one, and this is basically the surrounding environment and the context of the situation in which a person is getting care. Provider reputation and appearance is a really big one here. And so I have a 1 out of 5 stars because as I like to go out to dinner with my wife or go and eat at new places, I usually go to Google and look for that place and see if they have any reviews. And personally, if they have under 4 stars, then I'm probably just not going to go there because enough people have said that it's not good. And so I'm already being influenced by those contextual effects to change my perception and change my experience if I were to go to that place. If I looked and I saw that it was 2 stars and we went anyway, I'd probably be expecting things to be bad, and so my report or my experience might be very different than if it was 5 stars and I was expecting things to be really great. Clinician attire is going to be a definitely big one. People don't like clinicians in jeans. They like them in lab coats. And then clinician gender and race relative to the patient is going to be a pretty big one here too. Now, I will say the clinician attire can definitely change based on the context. If somebody is working out of a gym, it'd be a little bit weird if they were in a lab coat. And if somebody was working in a post-op floor, it'd be weird if they were in Gymshark attire. Expectations and beliefs, I think, are basically the umbrella that all of these contextual effects sit underneath, right? We want not only the provider's expectations and beliefs to be in sight, but also the patient's. And so one of the questions that I ask patients when I'm interviewing them is, what's your expectation of what's going to happen here at physical therapy, and what do you believe will help with what is going on here? And so I can kind of gauge where they're at because I know that it's going to come into play a pretty big deal. So enthusiastic practitioners and their optimism or pessimism regarding the nature of a treatment can have an effect on the outcome. And there's two different effects here: the Pygmalion effect, which is the positive aspect, and the Gollum effect, which is the negative. And they're basically self-fulfilling prophecies, right? If I am really excited about a patient who comes in that is a powerlifter, because I like powerlifting, because I like strength sports, I'm going to be probably more enthusiastic. They're going to feed off of that, and they're going to be enthusiastic. My intervention is probably going to help them better because we're both amped about it. And then because they are amped about it, they're probably going to respond well to it, which is going to make me feel that that intervention is good and that I should use it more often. And that same effect can happen in the opposite direction too. A patient's preferences and previous experiences about a physiotherapy treatment are able to modify the magnitude of the therapeutic response as well, just because of the way they are paired with prior positive or negative results. And so this goes back to that expectations and beliefs, especially if they've had this experience in the past. This gets a little bit into predictive processing, which I really don't think that we need to touch on hard here, but it does talk about learned responses and past experiences influencing current things that are happening, right? If I've been to a Mexican place before and I'm going to use food again, and it just didn't go very well, and I'm going to somewhere similar that maybe they have the same name or a similar chain, my past experiences and learned responses to that experience are going to shape how it goes this time around. Post hoc ergo propter hoc. After this, therefore, because of this, because an event occurred first, it must have caused this later event. So when considering patient improvement in symptoms, just because you prescribed an intervention and then the patient improved does not mean that they improved due to your intervention. And it comes back to that idea that the patient comes in at a certain point in their healing process or their recovery process, and then you apply something while they're going through that natural history and regression to the mean, and then on the other end of rehab, they are better, and you are misattributing your interventions to they're getting better because they happened in a particular order. And so the funny comic down here is the baseball players are headed south for spring training. Pretty soon the geese will all fly back north. Somebody needs to look into what those guys are doing to the geese. So next we have polite patients. And believe it or not, patients are willing to sacrifice their quality of life and disability to make sure that they don't hurt your feelings. Many patients don't want to disappoint their therapist by failing to respond to the therapist's sincere efforts to help them. And this desire on behalf of patients can bias reports of outcome. And so I try and be very upfront with my patients, and I say, hey, if things didn't work out, please tell me, because it doesn't help you or I if you lie and tell me that things are better than they really are, because then we're just kind of left here with you not feeling good and me thinking that the things that we did worked, and then me applying those things to other patients, which is not very helpful. Recall bias is an interesting one, and it's basically just our memory sucks. The systematic error that occurs when participants do not remember previous events or experiences accurately or omit details. The accuracy and volume of memories may be influenced by subsequent events and experiences. And so I can remember almost all the bad experiences that I've had with patients because they're burned into my memory. And those can contribute to the days that you feel like, or the weeks that you feel like things just aren't working out. You're not a very good therapist, and nobody's getting better. But it's you misremembering things because of recall bias. Now, the way that we can spin this for interventions is that if I can, remember that everybody with a barbell training intervention got better, then I might put too much weight into that method because I'm not remembering all the ways that it didn't work out because my memory is biased. Confirmation bias. This is definitely an interesting one. I think more people are aware of this one, but it's basically kind of twisting things to confirm what you were already thinking about stuff. The tendency to interpret new evidence as confirmation of one's existing beliefs or theories. And so the patient, I give them squat, bench, deadlift, or snatches and clean and jerks as a home exercise program, and they come back and they say that they're not any better. I can find a way to, I'm sure, point fingers and twist the way that they did it so that it was like, oh, well, no wonder it didn't work. You didn't do X, Y, Z, or trying to twist those effects so that it can confirm my bias because I don't want to be wrong. Now, survivorship bias is definitely an interesting one. It comes from wartime, where they would try and figure out why or where to better fortify planes that were getting shot at. And it's a logical error of concentrating on the people or things that made it past some selection process and overlooking those that did not, typically because of their lack of visibility. And so if we apply this to the clinic, when you look around, it seems like everybody is getting better, or the ones that are still here are getting better. But basically what's happening is that the ones that weren't getting better, or the ones that were harmed from your treatment, or the ones that thought you were a jerk, just never came back. And they left and they told all their friends that you suck, and the ones that are benefiting from and feeling better from therapy are the ones that stuck around. And so that can skew your belief in your clinic and in your treatments, because it seems like everybody who's here is improving, and that's because the ones who weren't filtered themselves out. And healthy user bias, this is basically the tendency of patients who receive one preventative therapy, like coming in for physical therapy or chiropractics, to also seek other preventative services or partake in other healthy behaviors. Patients who choose to receive preventative therapy may exercise more, eat a healthier diet, wear a seatbelt when they drive, and avoid tobacco. And so if we're trying to create an environment where people will succeed, we're trying to tend to the garden and make sure that it can grow as well as it can, we want to do all these health promoting behaviors. And so the people who are self-selecting themselves to come into the clinic to get better are likely also doing other things that are going to help to compound that improvement process. And let's wrap this up with the so what. There's a bunch of holes in our brain. There's a bunch of ways that we can't see things. So what? The patients are getting better. Who cares? And the so what is that any unnecessary exposure to the medical system has a non-zero risk, right? If somebody doesn't need to be with us, if somebody doesn't need to be in care, then we need to kick them out. We need to get them out on their own, because anytime that they come in, they have the ability to hear something, or they have the ability to be referred somewhere, or get some sort of intervention, or talk to somebody that is going to negatively influence them. And so if there's no need for them to be here, or they can do things on their own, then we need to be medical conservatives, and we need to try and do as little as we need to get them better and not anymore. And we also need to be careful what we're portraying to our patients regarding what is actually getting them better, kind of cycling back to narratives. The phenomenon of regression of the mean also has implications for patients' beliefs regarding treatment efficacy. Patient populations may embrace ineffective pain treatments that are expensive, risky, or both when their use is followed by a reduction of pain. And so not only us as clinicians are getting fooled by this, but we're also fooling our patients to think that if the same thing happens again or something similar, then they might need a similar intervention, whether or not that was the thing that got them better. And we need to keep ourselves in check regarding how much we as clinicians are actually helping to improve patient presentation. It can be a tough talk to have with yourself, to say, I don't think that I'm making as much change as I thought I was, or I don't think that our career field does as much as we thought it did before, because a lot of the stuff that we do just doesn't have a whole lot of good evidence to support it, and that's a tough sell for a lot of people. And lastly, new interventions must be vetted, studied, and attempts at logical reasoning must be left out until we're able to see efficacy studies or some controlled science removing our bias from it. The orthopedic surgery career field is really bad at this. They think up a new surgery and then they just start doing it without any sort of science behind it. And when they do randomized controlled trials, it shows that a lot of their surgeries aren't any better than the placebo surgeries or the sham surgeries, or just conservative care. And so if we try and reason our way through things, it usually doesn't work out. And this is a really good infographic, or a figure from a study released by JAMA a couple of years ago that talks about just this. We see that common sense in clinical observation or real world evidence doesn't really work out due to a few things. Incomplete understanding of pathophysiology, biases and unmeasured confounding effects or variables, and an incomplete understanding of treatment risks and benefits in a complex system like the human organism. And we can see that when we do it, we have a treatment and we run it through a randomized control trial, it does a better job of getting to that true outcome that we're looking for, and it removes as best as we can all that bias. And all that bias is really stuck together in this one picture here, the cognitive bias codex. Now, from my understanding, this is all of the cognitive biases that we currently know about. I could be wrong, but it's quite a lot, and you can see that there are multiple branches and multiple different ways that there are holes in our understanding of our reality, really, and our experience. And so when there's this push to try and logic your way through things, or trying to convince yourself that you're right and everybody else is wrong, just remember that there's a whole lot of things that are going awry in your head that basically make you the main character of your own story that might be clouding your ability to see things correctly. And I want to end on this, the I've seen it work. When somebody looks at me and earnestly says, I know what I saw, I'm fond of replying, no, you don't. You have a distorted and constructed memory of a distorted and constructed perception, both of which are subservient to whatever narrative your brain is operating under. And so this is a really good one, again, just to try and look yourself in the mirror and use some self-scrutiny when you're trying to convince yourself that you know better than the science, or you can intuit things better than we might be able to study them. And so I really like this quote, and try and end on this and look at it pretty frequently. And so that's all I got. I appreciate sticking with me. And if anybody has any questions, please email me at acrossthecontinuum@gmail.com, or follow us on Instagram at acrossthecontinuum. And have a great day.